Well, hi and good evening. It's such a pleasure to be with you all today to celebrate International Nurses Day. I'm Chiara and I'm the Director of Patient Services, a team whose success often relies upon the involvement, advice and support of incredible nurses, much like the panel of guests we have with us tonight. Before we get going, I just wanted to remind you that we're recording this session so we can share it on our social channels right after. So again, I'd like to invite you to turn off your cameras. It's been my privilege to work alongside some of the country's best nurses, both in the NHS and here at Anthony Nolan. And I can say with absolute certainty that there are very few specialities outside of haematology and transplant that demand so much from the nurses and the wider team. Our doctors are inspirational and amazing, but the nurses, we all know it's the nurses that are the beating heart of the NHS and our transplant centres. They are the lifesavers and the life changers, and they deserve to be celebrated today. Tonight, we're going to discuss some of the challenges that 2020 brought to transplant services. But more importantly, I'd really like us to talk about the opportunities and the hope for the year ahead. We all love to answer questions about transplant. So if you have any questions for us, then we'd like you to pop them in the chat at any time and we'll cover them at the end. To do that, you click the symbol that looks like a speech bubble at the top of the screen and it will say show conversation. Click that and you'll be able to see the other questions, but also submit your own. If there are any that we don't get a chance to answer during the live session, then we'll get back to you individually as quickly as we can. So on to our guests. Tonight we have 4 remarkable nurses, 3 of whom are experts in our wonderful world of transplants, and 1 who has her own lived experience of being a recipient of one. John is a nurse clinician from the Christie in Manchester, a hugely experienced nurse and the current president of the nurses group for our Pan-European Transplant Society known as EBMT. John has always been a massive supporter of Anthony Nolan Patient Services and was a great help to me, particularly in the early days in 2013 when we were just starting to establish how best we could work with our NHS partners. Sara is the lead nurse in transplant and cell therapy at Southampton University Hospital. Sara currently sits on the committee for the UK branch of EBMT that promotes and benchmarks the work of nurses and allied health professionals working in transplants. Throughout the pandemic, Sara has also been so helpful to us, supporting me and the team, and especially our own lead nurse, as we've all navigated our way through 2020 and into 2021. Laura is an advanced nurse practitioner at Cardiff and Vale Hospital. She's been establishing some really fabulous and pretty innovative services for transplant recipients, and her post has recently been adopted by us, so we can continue to learn from the excellent work that she's initiating in Wales and share that best practice across the UK. And Trudi. Trudi is our patient representative today. In 2018, she was diagnosed with leukemia, and it was quickly decided that she needed a transplant to survive. Trudi, I'm really looking forward to hearing your unique perspective as an expert in the field of nursing, as well as a patient recipient of a transplant. I know that you are very open and honest about the psychological impact that journey has had and continues to have on you. So thank you and the rest of the panel for coming along and being so generous with your time this evening. So on to the questions. So to start us off tonight, I'd like to ask John to give us his thoughts about what it is to be a nurse in transplant, and then a bit about what your current day-to-day role involves. Over to you, John.
Well, thanks very much, Chiara, for the very kind introduction, and thanks for inviting all of us here. It's nice to meet Trudi for the first time. I think I know the other people. Just one small correction, I suppose, and I know Michelle Kenyon's probably on the call somewhere and might be quite upset by the fact that I've just stepped aside as the president of EBMT a couple of weeks ago, and actually Michelle Kenyon is the new president now, so I must defer that position to her now. So a small correction on your introduction there. Nursing in stem cell transplantation, crikey, where would you start? So for me, I first started looking after stem cell transplant patients in 1990 as a student nurse. And I think that from that point onwards, I got the bug really, and I've been in transplantation ever since. And I think it's looking at the way that the nursing role has changed throughout the time that I've been a nurse, and the different nurses that work in transplantation, which I think for me in haematology transplant is the really exciting thing, that we've got auxiliary nurses or HCAs or whatever they happen to be called in your centre, or newly qualified staff nurses, more senior nurses, up to your ward manager, and then the specialist nurses, your CNSs, positions like myself as nurse clinicians, nurse consultants. And we have such a wide variety of nursing input at different points in people's journey through their cancer and through their transplant process, all the way through their diagnosis, their initial treatments, the actual transplant itself, and their post follow-up care. So I think when you say, tell me a little bit about nursing and transplant, the subject is just, you could write a book on this and we'd be here for hours. I know your anxiety was that we'd finish at 6:15. I think just asking one question, what is nursing in transplantation, we could be here till tomorrow. And I think that I take all of the things that I've been exposed to myself. So when I was a student nurse, I saw all these fantastic people running around looking after, at the time, really sick and very unwell patients in the late 80s and early 90s. Transplant was really, really difficult for people at that point. I think as it's worked through my career, it's not that it's got any less difficult, because we're giving the same chemotherapies, we're using the same radiotherapy, we're getting the same cells. There's nothing different in that. What has changed is the way that nursing care has changed, the way that our processes have changed, the things that we have learnt over time, and how we can give that knowledge to our patients and enable them to get through the process a little bit easier. It's never easy. It's not as though you can suddenly make a transplant easy because I know a little bit more about it and I tell you, well, you're going to get a sore mouth. That doesn't help you. But if I've read something about how do I look after a patient with a sore mouth, I can then look after you better, and I can give you information how you can help yourself look after your mouth better. So I think that education as part of that learning process that I've been exposed to since the 90s has really made a difference. And I think from a nursing perspective, and what it means to me, what nursing means to me is constantly learning something. And as part of my role at EBMT as being the president, I just really wanted to push that education agenda. And I think that patient care is improved if we can improve the education of the nurses at the bedside, and whether that is your healthcare assistant, whether that is, even people who aren't exactly nurses but are part of the nursing role. So it used to be that, you would make people's breakfast, and I remember microwaving bed sheets and taking those into the room before you could use them, and microwaving the newspapers and making the bed, and you would do everything as the student nurse and the nurse looking after the patient. Now there are other people. We've got other healthcare assistants, you've got other healthcare workers that are helping within that role. They need education as well, because they're still looking after the patient. Some of the roles and responsibilities from the nurses at the bedside have sometimes taken a bit of a step away and become more managerial and a little bit less hands-on. So the people at the bedside who are actually touching the patients, being with them every day and physically caring for them, need to understand what is going on. So for me, nursing involves education at every level for every person who's looking after that patient, and how you can best get that across to the patient, their family, their carers, their relatives, and the important people in their lives, so that we can make things better for them whilst they're under our care. And as anybody who's had a transplant, you're under our care forever, because we never give you away. We're greedy like that. We're transplanters. We want to know what happens to you. We want to know if there's a problem in the future. So we keep inviting you back to late effects clinics, not like other disease groups with, they see you, they fix your broken leg and off you go. You never see them again. We want you back year after year so that we can see you. We can see how you're getting on. We know all about your families, your dog, your holiday you went on. And we look forward to seeing people in clinics so that we can catch up and say, how have you been? How are you doing? How are you now? And that's all part of that educational process. And teaching people that, you can't sometimes do that directly in a classroom. That has to be kind of at the bedside thing, and the exposure to that environment, the place where you work, where people are used to doing that, and it becomes then a shared kind of thing that you just generate. I've talked enough for a minute. Somebody else speak.
I really like that idea, that education at the bedside, and I think you're absolutely right. We can't just educate the medics and the CNSs, because there's so many touch points for patients across the whole MDT, and everyone plays such an important part. I think I know that we're very much involved as an organisation and as a team around that professional development across the piece. So it's really good to hear that that's something that you're doing in Manchester, John. Thank you very much. So, Laura, you've developed some pretty amazing services in Wales as well that aren't possibly happening across the UK. I just wondered, could you tell us a bit about what one of your best days looks like? And again, for you, what being a nurse means to you?
For me, really, every day is variable. So from what John said, you're never going to have 2 days the same. They're all split into your clinical duties, which is probably the most rewarding part. And again, it's creating that environment as a nurse that you're empowering everybody to look after this patient, but to have that knowledge to share. So yeah, education is a huge part. And again, then I guess it's about prudent healthcare and making sure the most appropriate person's doing each job as well, and that everybody in the team does feel empowered to be able to care for the patient in that holistic way. So, about educating the whole team and valuing the whole team. Then the other parts of my role really would be more of the sort of leadership side. So seeing how things are running now, what is running well, but then kind of looking to the future, how new treatments are developing or what's changing among in the field, to then see where we want to move on from that. So I'm sure I've probably spoke to some of you about the prehab before, but again, that's really probably the biggest task I have at the moment from a leadership side of things, trying to get every patient to be assessed pre-transplant by a whole multidisciplinary team. So from the physiotherapist, the OT, a pharmacist, and the psychologist, really to us all to assess that patient individually, and then to have a MDT afterwards to discuss each patient from that very early point. So really, you can optimise how fit they are at that pre-transplant phase to hopefully reduce some of the complications post-transplant. So yeah, I guess a big thing as well is just kind of having that overview, but also seeing where there are gaps in research and what we can all do together to address this, and then sharing our knowledge again across the country, really, I suppose. Yeah. I can't remember what else it's saying now.
That's lovely, thank you. I'm really glad you brought prehab up. As you know, it's something that I'm really keen to put a huge focus on in the next year or two, certainly as a team at Anthony Nolan. And I definitely see the value in really optimising that patient before they even go anywhere near their transplant, just to make sure that you've covered as many bases as possible before they head into that big complicated journey. So thank you for bringing that up, and I was hoping you were going to mention that. I'm also delighted that President Michelle Kenyon has only just joined us and missed me giving John the wrong title. Hello, Michelle. Okay, Sarah, on to you. Thank you, Laura. I'd like to ask you this next question. So you have a superb team in Southampton, and I'd really like you to share with us how your team responded to the pandemic back in March 2020.
Thanks. It's great to be here on International Nurses Day. I think that transplant nursing truly is an international activity, particularly when we think about our donors and the donor registry activity that is coordinated through the Anthony Nolan. So it's really great that we're able to celebrate at this forum. Thank you for asking me about COVID. It's been what has been at the forefront of our mind in many ways for many, many months. But what I think is really important, particularly for us as transplant nurses, is that managing the risk of respiratory viruses and infection is what we do. It's our bread and butter. And so we really were on the front foot in terms of being able to respond to the threat of COVID. We knew we had to protect our particularly uniquely vulnerable transplant patients from COVID, but we also knew we had to protect them from their disease, and we had to continue treating them, and we had to continue transplanting. So a lot of our activity was around protecting that and protecting those processes. All donor transplant centres sit within large university hospitals, large NHS organisations, where all specialties were being called to adapt and have a response to the pandemic. At UHS, we were really fortunate. We had a COVID zero sort of ethos, and everybody knew what we were about at that time. But what it meant for us as transplant nurses is that we had to be particularly strong in advocating for what transplant patients needed, what this really meant to them, and the very specific needs that they would have in this threat. So we had to make sure that we were able to do that and articulate to other areas of the hospital who may know nothing about what we were doing or the risks that our patients particularly faced, so that we were all able to be coordinating in that effort. And we also had to support the call to support nursing across the whole organisation. You know, there were reduction in nursing numbers, the changing of ward configurations, changing of theatres and intensive care, and they needed the whole of the nursing workforce within the organisation to make a response, and we wanted to play our part in that as well. So we had a number of things that we needed to balance. We needed to know that wherever our patients were within the hospital, because things changed so dramatically, that they were looked after appropriately. So whether they were on our transplant unit, whether they were in acute oncology, whether they were on a COVID ward, whether they were in medical admissions, A&E or ITU, we had to be there in one form or another to make sure that they were looked after as they needed to be. And it was all about collaborative working with nurses who may never have seen a transplant patient or understood anything about hematological malignancy. One of our most critical roles, as always, was to be at the bedside, and we've talked a lot about being there with patients, but we also had to expand to fill that space that was left at the bedside when hospital visiting was halted. And nurses and the other members of the ward-based team were very much the people who were there with patients. But we were also able to facilitate virtual visiting, virtual consultations, to bring relatives into the hospital room where they would have been had we not been facing such a particular threat in terms of infection. We also, particularly the specialist nurse team, coordinated hundreds of PCR swabs for relatives and next of kin to enable them to be with particularly vulnerable patients or palliative patients, and those having critical diagnostic or treatment consultations where things were really needed to be put in front of everybody and their loved ones together in the way that they would have been done had we not been in a pandemic. So we made ways to ensure that people were supported in the way that they would have been before we even knew what COVID-19 was. We made a lot of changes to our patient pathways. We physically moved our day case unit and our clinic off-site so that we were able to continue to see people face-to-face. It is absolutely imperative within transplant follow-up and when you're consenting somebody pre-transplant, that you're able to have those in-depth conversations in person. And so we constructed those areas, those outpatient areas, in a safe way so that we were able to continue doing that, where a lot of services simply halted their face-to-face consultations. The clinical nurse specialist and the other members of the specialist team, including our quality manager, our data manager, our office manager, the admin supporters, the coordinators and the CNSs and the advanced nurse practitioners all responded and were adaptable to the challenges that were in front of us. And I think it is has been an absolutely proud moment of my career to be part of that and to see how this team has swung into action to ensure that we've been able to continue transplanting and meeting the needs of our patients and their families.
Thank you very much. I remember talking to you back in the summer and you were walking me through the process that the whole team has to go through just to allow one relative to visit one patient once a week. You know, the time points that the things that you needed to do, and I'm delighted to hear that you're able to protect those difficult conversations, because also what we've heard over the last year is that hasn't always been the case. So I really learned a lot from our conversations about how, when you get it right, what an incredible impact that can have when everything seems to be falling down around you. You've managed to stand tall. I'm sure you're incredibly proud of your team. Thank you for sharing that. Trudi, over to you. You have a pretty unique perspective, a lead nurse yourself that has been dropped into this long and complicated transplant journey. I'd really love you to share a bit about what being a nurse means to you, of course, but how the nurses in your transplant team supported you during and after your transplant.
Thank you. Yes, it's, oh gosh, where to start in a way. My life was irrevocably changed by AML, whirling into it kind of completely unexpectedly, really, back in March 2018. And until then, I was, fully employed nurse. I'd actually reached a kind of chief nurse, director of nursing level, albeit within a small organisation working in primary care, mainly GP out of hours primary care. And most of my nursing career has been in primary and community care. So my understanding of leukemia was very top line only, really. And then the rug completely pulled out of me, obviously, when this all happened. Which I know we're not really talking about fully today. This isn't just my story. So if I jump forward, I did get back into work. I did work, got back to full-time post sort of for about a year, 18 months after everything that had happened. But I couldn't continue to do it. I did it for a few months. I got a pneumonia very quickly after coming back. So I'm actually finding myself poised now on retiring on health grounds. So being a nurse for me is something that I have always been. It's always been in my blood. It's always been what I've done. And to now actually be possibly looking at not being a nurse, I'm finding that a very, very difficult point to come to. However, AML is life-changing. It has completely changed my life, and I know I have to live for the now. I have to live for today. And listening to everybody today, it's very strange as a nurse, because one of the things I think that this experience has done to me is I used to be in control. I used to be like the faces I'm looking at now. And obviously I know Sarah, but I've not met Laura and John before. And I could tell the story. I could say what's happening. I understood that. And to be on the other side of it, to be the patient who, when the consultant walks in or the team walk in and you've got the biggest blooming notes on the trolley, and to be, to be the hospital number every time, that is a very strange position to be in as a nurse. And as you all know, when you have a leukemia and a stem cell transplant, it's not quick. I think somebody's already said that. It's a really intense, long treatment, not only while you're in that critical phase, but forever. And so you don't stop becoming a patient. You don't just go in and have something done and quickly get over it. It is a hugely, hugely impacting experience. And going back to the role of the team for me, I mean, I know everybody's experience is different, but when my AML happened, I was unfortunately really, really critically ill. It was very, very quick, and initially given a sort of 50-50 chance to get through the first few days, and already got some liver damage and some kidney damage. And it was a complete maelstrom whirl, and there are lots of things I don't remember, lots of things I didn't care about. I even almost didn't care about living at one point. It was when it was really, really bad. And I actually thought I might not make it, but I did. And one of the things that I would say is absolutely staggering about the transplant team is you've gone through something like that. For me, I've gone through that critical point where I nearly died. You can get your head around, you hardly ever get your head really around that, but you go through that bit, and then you're moving on to your slightly more in control chemo rounds 2 and 3 while you're at that point of facing the transplant. And I really didn't want a transplant, and I did see someone I know on the call who knows all about this with me as well, and I really didn't want it. You've gone through something that's nearly killed you, and then you're being asked to go through another thing that might nearly kill you or kill you, and that is so frightening. And I think those conversations that the team are able to have with you, and I remember many of those, you know, nobody sugarcoated it for me. Everybody was realistic, but it was the I don't want to use the term package of care, because it's not package of care, but it's the way, it is almost like the loving care that's wrapped around you by the team to keep you safe is what the team deliver to you. And that is based on trust and honesty, because, you know, you are letting yourself, your life be up in your hands, and that's very hard to explain how that makes you feel unless you've been there yourself. So I would say it's definitely about trust and honesty. So also I found particularly the CNS team are your port in a storm, because I never ever felt hurried by them. I never ever felt any of them didn't have time for me, and other staff or medical nursing, everybody, and I you know, I've been that one too. I know how hurried and harried you can be, and it does show to patients sometimes. But from the CNSs, I always felt you had the time for me, no matter how late the clinic might be going, if it was in clinics afterwards, or if you'd come into my room in the time that I was in for the transplant. I wrote a couple of other things down that I said. The last thing was really just about, because I still have chemo brain and forget things. So the last thing was, and John, you said it right at the beginning, you are a patient forever, and I do feel like you guys are there for me for the whole journey. I even now, you know, getting to 3 years on, I still sometimes think, oh, could I ring them about that, or should I go to the GP, or should I? Oh no, I'd much rather go to the CNS team. They're the ones that know me. So yeah,
I think that's how it works, Trudi, isn't it? That's the beauty of them. I really liked that image of that loving care wrapped around you. I think I completely agree. That's what a transplant team is all about, and certainly the nurses that look after you so diligently. And I think somebody's put this in one of the comments actually, and I was going to say it myself. Being a nurse isn't what you do, Trudi, it's who you are. So I'm sorry that you're at a really difficult crossroads and having to make an incredible, difficult decision, but you will always be a nurse. So thank you very much for sharing that with us. Thank you. So before we jump away from the last year, I just wanted to quickly ask perhaps Sara, if you could tell us what one of the biggest challenges has been in the last year and how you've dealt with that in Wales with your team.
I guess really for us personally, a lot of that is keeping patients safe, and to be able to, you know, still have that social distancing when you're limited in your facilities some of the time. So, you know, you had to be wise about this, haven't you? So part of that, for the patients being admitted, we didn't have any triage area or anything at the start of this. So that's been a real benefit actually, that now we've got like almost a triage ward really. So, you know, rewriting all of the pathways really to make sure patients are only transferred when it's safe to transfer them after admission as well. And that's something that we are actually going to be able to maintain longer term. So that's been a benefit. But then again, trying to manage that social distancing through the day case. I think clinics, it's been slightly easier. And originally for the day patients coming through the day unit, it was okay, and we were open sort of 7 days a week initially until things settled. But as more treatments have been coming back in, that's still been a challenge. So it's been, you know, constantly actually thinking ahead, staying on the ball, knowing what's happening from week to week really, and actually continuously assessing the situation and planning from there, I suppose. So yeah, that's what we've personally found most difficult here. But again, you know, everybody's just worked together, and that's a testament to how things have been managed, that, you know, the whole team has pulled together, and it's been amazing really.
You've done a great job. And how about you, John, in Manchester? Has there been one particular big thing that when you look back now that was a real turning point that you thought, crumbs, I don't know how we're going to get through this? That, you know, what was the really big challenge that you guys had to deal with?
Just before we move on to that, Trudi, are you okay? You sure?
Yeah, I am. I didn't expect I was going to get emotional, but I am. Thank you.
Okay. It brings talking about things like in forums like this brings up a lot of memories, I'm sure, of what happened in transplant and chemo and all that kind of stuff. So, you know, if you want to turn your camera off for a minute and, you know, have a drink, kick the cat, something like that, you know, don't worry, we'll still be here when you come back.
Yeah, I am fine. I think it's the career thing as well, you know, the nursing thing. Yeah. Thank you.
Okay. So in answer to your question, Cara, I'm not quite. I'm probably an outlier, I suppose, in most of the NHS. For the trust that I work in at the Christie in Manchester, is we're similar to the Marsden in that we're a cancer site specific area where we don't have an accident and emergency department, casualty. We don't have random walk-ins that could be carrying COVID. So in that respects, we're quite fortunate in that we're able to very closely guard our entrance for the appropriate patients coming through at the appropriate time. So for us, that means that we can manage exactly who is coming through our door. So for the transplanters, we initially had a small downtime of it was about a month, 5 weeks, where we said, right, we really don't know what's going on with COVID, how this is affecting people. Is it more risky to do them now or not? We really don't know. So in a lot of places across the country, it was probably similar. They either slowed down their admission policies or shut altogether for a few weeks. So we took the decision to shut completely for a few weeks, to look at the landscape and see how that was developing, and then could we safely open, and then changing all of the processes in place. So our waiting room downstairs, for instance, used to have 40, 50 chairs in it. I think there's 6 now. So, you know, social distancing gone bonkers. You know, you literally can't sit down in the waiting room. So that means that if there's nowhere to sit in the waiting room, then you can't have people in the waiting room. So where are they? So they're at home, or they're in another place in the hospital. So we've moved our phlebotomy department. We've got an ambulatory care and a TYA department that have been split. So we've got patients now, instead of being in the ward and our outpatient department, spread across 4 areas to dilute the patient contact, so that we're hopefully reducing footfall, we're reducing transmission of COVID, and like Sarah said, it's trying to maintain, you know, however you want to use the word normality. We can't be normal, but it's how do we maintain the service within the restrictions that you're going to have to adopt to keep people safe. And at the end of the day, that's what we're trying to do, is we're trying to keep people safe in the best way to still deliver A+ treatment, because transplant isn't just fixing a broken leg. And I've said this before, I'll say it again, it's a big process, takes a long time, with lots of complications and lots of touch points where things can go wrong. So if you haven't got decent processes and procedures in place, then something will go wrong, and your patient then becomes at risk. And at risk for a transplant patient is dead. You know, at risk for somebody else might be an ingrowing toenail, or, you know, I don't know, something innocuous. But, you know, for our patients, you know, sepsis followed by death is not uncommon. You know, so we've got to be really, really mindful of what risks we're putting people at and why we're putting them at that risk. Do they have to come to transplant clinic today? Can I put them back and just see them every 2 weeks, or can I see that person every 3 weeks and then phone them in the meantime and do it in a slightly different way? So I don't think there was a crashing moment where we suddenly realised, oh crikey, it was more of a development across time and over a few weeks and a few months. And it's going to keep adapting. There's no way that we can go back to how we were with the best will in the world. COVID is here to stay. It's not mutated out of its comfort zone yet. So, we're going to have to keep getting vaccinations. We're going to have to keep being socially distanced. We're going to be mindful of transmission of disease. So for us, transplant across the transplant world is going to be slightly different than it was 2 years ago. And how do we all continue to adapt to that, really?
I think we're just starting to hear that loud and clear, that this, certainly in terms of what happens next, that we try and put the bad stuff behind us as best we can and move forward and leverage some of the positivity that came out of having to react and be agile and change the way that we deliver care, often in a way that's more beneficial to patients. Do you need to get your patients in on a 3-hour trip to get some normal blood results? It's kind of bonkers that we ever did that, and to think that, like you say, we just will never go back to that kind of care. So, and I think also the picture that you're all painting that perhaps people hadn't appreciated before this evening is just the level of complexity about just the number of plates that you're spinning, just knowing where your patients are in the hospital, and coming out of that, I'd imagine, is going to take a really long time. So it's not lost on us. And, if it needs saying, we'll keep saying it. If there's any way that we can support any of you to get through the other side of this, then we will absolutely do everything that's in our power to do. Thank you, John and Laura. So as we've said, we have made some great progress in the sort of COVID restart agenda, the vaccination programme, for example, but I'd imagine that there are patients awaiting transplant that are still pretty nervous about the year ahead. Coming into hospital for clinics, actually having their transplant, will that look different to what they were anticipating it was going to be? Will they be allowed their visitors to come in? So what advice can you offer your patients or anyone watching this that might reassure them that all the complications that we've been talking about this evening, but everything will be returning to as much as normal as possible, and that everything has been considered to keep them safe? So, Sarah, perhaps we can start with you in Southampton about what sort of reassurance can we offer people that are heading towards this transplant journey?
Well, as I said at the beginning of my little spiel earlier on, managing risk, and particularly the risk of infection, is our business. It's our bread and butter. And so and I certainly saw this from an organisational point of view, we were ahead in terms of thinking about how we would be able to adapt to keep our patients safe and keep doing our daily business in terms of treating and transplanting patients. But anybody who is got their transplant in front of them at the moment will also have heard us talk about your relationship that you develop with your transplanting team and with the different members within that team. And there'll be lots of people that you will have relationships with. And my advice would be to lean on them. This is what we are here for, to support you through your transplant journey, whether it's in front of you, whether you're in the depths of treatment, whether you have difficult symptoms, whether you're recovering or in long-term follow-up, whether we have got rid of your leukemia or if we have not, we're there to be alongside you wherever your transplant and treatment journey takes you. There aren't secrets about what is happening. We are happy to explain, and some of the concepts within the treatment are very complicated, and so it may take a different person to explain it using different words. And if you need to keep seeking that information that will reassure you, and we're here for that. I think that even though what John was describing in terms of things looking different, the waiting room is not packed on a Thursday morning between 9 and 1, everybody's squeezed in together waiting for hours on end. It doesn't look like that anymore, but it doesn't mean that you won't get the time that you need. And if you don't get the answers at that point, you need to come back to us. So I think that the other thing to also be really mindful of is how COVID has been such an important lever in terms of virtual consultations, and how we are connected even more with our patients and with our colleagues, our referring hospitals in the region and other transplant centres. So we're able to share knowledge and have conversations in different ways. We talked for a long time in our service for years about having telephone clinics and video clinics for the long-term follow-up patients. And we have we talked a lot, we wrote a lot of plans. COVID came and we had to do it, and it is here. And there is, as has been said a couple of times, we're not going to go back. But I think we're going forward into a brave new time for medicine and nursing, and we can feel really excited about how that will allow us to be more dynamic and look after patients even better and attend to their needs even more in a sort of truly holistic sense. We have more tools with us to be able to do that, and that has been, if there have been gifts of COVID, that has certainly been it. It has allowed us to open our minds to some of these things as well as have some of the resources to do that. Certainly UHS Digital gave me a laptop the minute they knew my child might keep me at home isolating, and there I am working at home. So I think that there are many things to be positive about going forward, and we adapted to continue transplanting through the pandemic. So I think we'll probably be able to continue transplanting whatever comes next.
I have no doubt. Thanks very much, Sarah. And just Trudi, just out of interest, Sarah just painted a really good sort of innovative picture about what's been happening in Southampton. Have you got any experience of those virtual consultations? Did you do any of that during the pandemic or while you were shielding, for example?
Yes, definitely. I mean, I am a partly Southampton patient, as Sarah knows, and I have had the virtual consultations. I'm just waiting for a virtual bone marrow aspiration. Would be nice.
Wouldn't that be clever?
Yeah, so sadly I still had to go in for those.
It's good, but it's not that good, Trudi.
And I always felt very safe, I have to say. And I also, of course, when the facilities were moved to the was it a private hospital? Yeah, so it was a no COVID site, and that did feel very safe, I must say. So yeah, it's been okay.
Thank you. Before we move on to our last question, I just want to check with John and Laura. Is there anything from that sort of reassurance point that you're doing particularly differently in Manchester or in Wales about patients coming in the next year, how they need to prepare any differently about how you're sort of coming out of the other side of the pandemic, just before we move on? We're having a mute. There we go.
I wouldn't say massively. I think one other thing that's probably has helped these patients a little bit is there seems to be obviously a greater understanding now of the risks for this patient group, just because mainly of the media, I guess. But yeah, I think, it helps their families and friends understand a little bit more what they're going through, because most people don't know somebody that's had a transplant, that actually it might help from that point of view as well. But yeah, like Sarah said, this isn't anything new anymore. We're really used to doing and working in this way, and things are a lot better. The setups, logistics have improved so much. From that side of view, I wouldn't be concerned or any more concerned than what you're going through.
No, of course.
Yeah.
You, John?
Yeah, I'd agree with that. I think that people's anxiety is going to still be there, and it's real, and we can't deny that. I think if, for instance, I know what my department's like, but if you said to me tomorrow, right, we're going to admit you're newly diagnosed leukemia, I'd have a meltdown to myself, yeah. And I know what the inner workings are of the place. And that's human nature. We all worry. We're all anxious beasts. That's what we're designed to do. We're designed to worry about things and fret over them and go over and over in our heads again to see what's wrong and how we can fix it and the best way we can get around it. So I don't think we can ever remove that. But as Sarah and Laura have both said, having things in place to ensure safety and making sure you've done proper risk assessments and your place is as good as you can make it gives confidence to the patient coming in. And that's what we need to do is exude confidence. and say, we have things in place. I know how to look after you, and I have all the things in place to make sure you are going to be safe today, tomorrow, the next day, and the day after, because we know what we're doing. We know how to do it. Trust us. And that's a two-way street as well. You've got to trust each other. You know, you're asking somebody to trust you. You've got to trust them that they're going to do the things that you ask of them, as long as you hold up your end of the bargain and do the things that you're suggesting that you will do for the patient. So two-way street in everything, making sure that you're doing all the correct things. So that'd be the only thing I could add to that, really.
Lovely. Thank you, everybody. We've made it to the last question, and I'm going to ask each of you to give me an answer to this. So you've got 1 or 2 minutes. I think we've had some questions come in. I'm trying not to be distracted by them, but you can have your moment to answer this question. I love asking this. If I were to give you each £1 million to improve transplant care, what would be your ambitions and how would you spend it? And I'm going to start with you, Trudi. You've got £1 million from me. How would you spend it?
Oh my goodness. I was hoping you weren't going to ask me first, because it would obviously be to not even need transplants. That would be what I would be looking for. And I suppose, because I don't understand the research side like you guys and the latest developments or where things are going, but it would be anything that would move us closer to no one actually needing a blooming transplant would be it. And if it was going to be a bit more modest, it would simply be that the whole process wasn't so grueling, didn't have a 20% mortality rate associated with it, and was, good for anyone, no matter how frail or fit you might be. So something around that.
Wonderful, Trudi. I'm going to go around my screen this time, and John, you're up next. How would you spend the £1 million?
Well, when I read the question, I didn't get further past that. If you had £1 million, that's as far as I got. So when I was much younger, in a previous job interview, I said that I wanted to be the first nurse in space. It's a confession. I hold my hand. I didn't get the job, and if I had £1 million, I'd still like to go to space. But if we're using this for transplant care, the thing that we are missing, my department is missing very, very much, is psychological care and support input. And I think that is even more true now, certainly in this last 12 months, than it ever was before. We were always deficient because psychological services across the country, no matter what specialty you're in, are not as good as they could and should be, for a variety of reasons that we can't go into here. And I think that with COVID, again, people's anxieties and psychological problems associated with COVID outside of transplant have gone through the roof, and psychological services are struggling. And within transplant, adding that into the mix is making our patients even more vulnerable and concerned and worried and needing that specialist input. I don't have instant access to that. Our waiting list at the moment is, I think, 10 to 15 weeks to see somebody, which is a ridiculous amount of time. But it's because there isn't enough staff, and the service is flooded. So if I had £1 million, I'd employ half a dozen people instantly to try and help people through this.
Yeah, we hear that, John, and I share your concerns about how that psychological burden will only get more over the coming months as people are transplanted in this sort of uncertain time. So thank you. Sarah and Laura, you've got a minute each. Let's start with Sarah. Here's your £1 million.
I don't think £1 million's enough, but I think what John is saying is absolutely true. It's Mental Health Awareness Week, and absolutely we need to have integrated psychology services. If we talk about holistic care, how can we not have that as being an absolutely fundamental part of what we're doing? We've been very fortunate to have an Anthony Nolan sponsored psychologist attached to our transplant team, and it has been an absolute game changer for us. But it's not just been for all the patients. We're talking about International Nurses Day today, and as nurses, we need to fit our own oxygen mask before we can care for others. I think COVID has also put the spotlight on well-being of staff, and I think that it will force organisations to address that in a more meaningful way. But in terms of my £1 million for transplant, I think in general, that's what I'd be looking for, truly integrated holistic care. Therefore, all allied health professionals being able to have dermatology integrated, as well as ophthalmology, as well as cardiology opinions in your long-term follow-up, you know, having dietetic support all the way through and physio, to be able to target those really effectively, to be able to ensure that we have the best outcomes for people.
Yeah, I hope our chief exec is still on the call, because Henny, we're going to need a bigger boat by the end of this call. And finally, Laura, over to you. Here's your £1 million.
I would really just echo what the others have said. I think, you know, as nursing teams in most transplant centres, we are pretty well set up now, and a lot of that could be through Anthony Nolan funding so many posts as well. But I think, you know, we need to aim for a more equitable service across the country, and in terms of the allied health professionals, that's really where it's lacking. So yeah, I'd echo what they've said. You know, in my area, it'd be more looking at kind of physiotherapy rather than psychologists, because we do have greater services that we can offer on that front. And I think, you know, for physiotherapy, it plays a key role in the patients with GVHD as well. And I think that's the other area that needs a lot of funding, because GVHD obviously limits people's quality of life so dramatically. And for those patients with steroid refractory GVHD, I think, you know, there needs to be a lot more research to able to better treatment options, but also if there are any other areas that we can support these patients better as well. So yeah, they're the two key areas I would focus my funds on.
Brilliant. I'm sure there's lots of Anthony Nolan staff on the call that are furiously writing notes about what you all need. So thank you very much for sharing that. We've made it to the end. Thank you so much. That was brilliant. I've really enjoyed it. And I'm going to come to you, Jordan, if you're still on the call, because like I said, I think we've had some questions in, and we've probably got about 5 minutes if there are any that you can put to any of our panelists.
Yeah, sure. So the first question is for Trudi. Trudi, did you find it hard, having a nursing background, to understand the potential consequences of your illness and the effects of the treatment?
Yeah, I mean, I think that I'm sure you find it hard, whoever you are, but I think I think I said earlier that, you know, my knowledge of leukemia was fairly rudimentary compared to what actually happens. So some things just went over my head in the same way I'm sure that anybody else, it would go over their head. But there were other aspects that I did feel more, well, I don't know if I felt more anxious, but I certainly felt very anxious about, particularly things like reading about mortality rates and, you know, in the 7 Steps booklet, all the small sort of quite light little sentence about, oh, and in a small number of cases this would be, so I think those things really hit home. And like I said, the implications of having huge notes, knowing that that meant that you had all these additional risks, all these extra complications, that was hard. There were some elements that were a little bit, I felt some more control in some of the decision making about, say, simple things like whether I personally felt I really needed Clexane, for example, at one point. There were a few things like that because of my background, I felt I could make a more empowered judgment over, and sometimes understanding perhaps why you take something on an empty stomach, for example, was I knew that was important to carry on in that way, because I understood that. But it was a mixed blessing.
And then the next question is, how do new transplant patients become aware of the services Anthony Nolan can offer? What is the nurse practitioner's role in this?
Great question, guys. How do you promote our services to your patients?
So we talk to patients when we're looking for donors, and when we're talking about finding a donor and assessing a donor, and we explain who the Anthony Nolan is and what their role is. And so also many of our patients know your contribution to our psychology service as well, because I talk about that quite a lot. But it's a fantastic organisation with a huge amount of resource for patients, and we would certainly encourage patients to use it. And particularly, I always find it's helpful to encourage family members and next of kin to seek information from trusted sources on Dr. Google, and that is one of the places that you can direct people to.
Thanks, Sarah. Jordan, I think we might have time for one more, perhaps.
Yeah, so this is the last one. What can Anthony Nolan and the patient population do to push integrating physical and mental health for transplant population? I was treated at Barts, where they were fortunate to have Anthony Nolan psychologists, and it was integral to my treatment.
I think I need to answer that. What can Anthony Nolan do? Well, it's great timing, actually, because we're just starting to take a look at kind of what happens next. Patient services have been at Anthony Nolan for 8 years now, and we've kind of grown sort of thoughtfully and iteratively over the last 8 years. And because of the pandemic and because of some of the new innovative treatments that are coming down the line, now's a really good time for us to sort of take a look at what the opportunities are and what some of the things, how we can better integrate ourselves with you, with our NHS colleagues. And I think there's some really exciting things that are happening. We've talked about a lot of the things that float my boat this evening: prehab, physiotherapy, psychological support, some of the socioeconomic impact. I really strongly believe that where we can fully understand that patient before they have the transplant, that makes a massive difference to how they cope afterwards. So, and it's very much, we don't just expect you to come to us. And by you, I'm talking to our panelists. It's up to us to come and find out what you need and to continue in a conversation. You know, we have our lead nurse, Hayley, that left us a couple of weeks ago. She did a tremendous job at developing a network of incredible people like you. So we're always hearing from you. And I guess all I ask is for us to do our job really well, we need you to keep talking to us. But yeah, that is on us, and we'll continue to do our bit. But we know where these pinch points are. We know it's around psychological support. We know it's around supportive care. We know it's around what we can do with the families. We know it's around going back to work. So we'll just do our bit and do what we can to be even bigger and better in the coming years. But make sure we're doing it in the right way and spending every pound in the best possible way for our patients and for your patients, of course. So that's kind of all we've got left to say. So a huge thank you to our panel for your time and sharing your insights and hopes for the future. I've taken a huge amount from this evening as well. It's a privilege to spend a bit of time with you today on this special day that you absolutely deserve to be celebrated. And of course, if you'd like to find out more about the work of Anthony Nolan or of the patient services team, then head to the patient and family section of the website or the healthcare professionals section, which is looking great now. And we'd love to hear from you. Enjoy the rest of your evening, and goodbye from us, and thank you.